Okay, good morning, everyone. Thank you very much for joining us for the third in our CREMS webinar series. And we're very happy to have Dr. Mark Deady today with us, speaking on the use of eHealth to treat co-occurring mental health and substance use disorders in youth. My name is Lexine Stepinski and I'll be chairing the session today, and we'd be very happy to hear your comments and questions. So you'll see in your panel to the right there's a questions box, and we'd encourage you to just shoot through any questions that you have during the session, and then we'll have a Q&A session at the end to discuss those questions and comments that come through. Now, we also have an additional webinar coming up later this year, so in November. Just to let you know, we have Dr. Erica Crome, who will be talking about helping us with locating free resources to support evidence-based practice. In addition, we have the two previous webinars that we've had over this year, over 2015, are available from our website, so comorbidity.edu.au training webinars. You can actually watch the video if you've missed those webinars and download the handouts. So we have Dr. Kath Chapman, who presented co-occurring mental health and substance use disorders and looking at how they affect young people. And then Dr. Nikki Newton, who presented on drug and alcohol, how we can prevent drug and alcohol harms. So for those of you who are joining us for the first time, CREMS stands for the NHMRC Centre of Research Excellence in Mental Health and Substance Use. And what we're all about is conducting research to improve the understanding of mental health and substance use disorders, and in particular, understanding how and why these problems co-occur. And in addition, we're working to develop strategies and also conducting research to identify the most effective ways to prevent and treat these problems. So to achieve these aims, we work closely with services, schools and community groups, and this webinar series is another way that we can keep those communication lines open. And this is just a photo of the team at CREMS, and you can see there in the bright pink is Professor Marie Thiessen, who is the director of our centre. And so now it gives me very great pleasure to welcome or to introduce one of our very valued colleagues at CREMS, Dr. Mark Deady, who is a postdoctoral research fellow at the National Drug and Alcohol Research Centre and the Centre of Research Excellence in Mental Health and Substance Use. And since 2008, Mark has worked on a range of projects relating to comorbid mental health and substance misuse at the epidemiological, coronial, policy and clinical level. And he's currently working to develop a treatment portal for New South Wales health agencies. So we're very happy to have him speaking today, and I'll pass over to him now. He'll be talking about the use of eHealth to treat co-occurring mental health and substance use disorders in youth. Thanks and welcome, Mark.
Thanks, Lexine. So I'll start off by just giving you a bit of an idea of what I'm going to talk about today. I thought I'd just talk broadly about the prevalence and harms associated with comorbidity amongst young people. Then look a little bit at the different current treatments as well as the service utilisation of young people, and then get into a bit of what's going on at the centre around internet therapies and eHealth, just to give you a broad overview essentially of what is coming out of the research being done here. So I'll get underway. So first off, in young people, just as in the general population, mental health and substance use disorders are major causes of disability-adjusted life years. Worldwide, the main causes of years lost to disability for 10 to 24-year-olds were neuropsychiatric disorders, accounting for 45% in total. While alcohol was the main risk factor for incident disability-adjusted life years in this population, while illicit drug use was ranked third. And as you can see from the table there, it's clearly populated largely by both mental health and substance use disorders. So in addition to the obvious individual, family and societal impact of these disorders, the financial cost of youth mental illness is estimated at over $10 billion a year in Australia, with the cost of lost well-being estimated at a further $20.5 billion. In total, this actually amounts to a cost of over $30,000 per young person per year. And in terms of comorbidity, comorbidity across the disorder classes here is common. In Australia, the recent national survey for mental health and wellbeing indicated that amongst those young people with a current mood disorder, 1 in 4 also met criteria for a substance use disorder, while amongst those with current anxiety disorder, 1 in 3 met criteria for a substance use disorder, while amongst those with a current substance use disorder, almost half met criteria for either an anxiety disorder or a mood disorder. And why is this concerning? Well, essentially comorbidity compounds the problems faced by either problem in isolation, and it's specifically associated with increased rates of suicidality, hospital and emergency department visits and larger treatment costs, high rates of additional comorbidities, both mental and substance use, but also physical disorders, and also increased rates of early relapse, and also poorer functioning, quality of life, and they tend to have poorer treatment outcomes. And why is early intervention essential? Well, this is a critical period in which both positive and also negative health and social behaviours are established. And so during this sensitive period of growth, even subsyndronal or mild mental disorders have the potential to dramatically affect vitally supportive relationships or significantly disrupt career and study plans. Therefore, early intervention is vital to arrest these problems in the early stages. However, it really is not occurring. Although 1 in 4 Australians between the ages of 16 and 24 experienced a 12-month mental disorder, less than 25% of these affected young people have accessed services in the last 12 months. These figures compare with 1 in 5 of the general population having experienced a disorder, with just over 1 in 3 of that population seeking treatment. So you can see the proportional gap between those in treatment and those receiving it is actually widest amongst this young population. Sorry. So the reasons for this discrepancy are essentially complex. It's probably easiest to split into both individual components, such as the recognition of problems, attitudes towards problems and services, perceived stigma, the time and treatment commitments, as well as the structural determinants, things such as family and community support systems, referral pathways, financial cost of treatment, as well as geographical barriers, and a lack of relevant services. And so how can we use the internet to help overcome some of these barriers? Well, first off, we know that young people are regular online users. Furthermore, the internet has become an important source of health information for many young people. In fact, after email and search engines, searching for health information is one of the most popular online activities for young adults. That brings us, I think, to a first poll here. So if people would like to log in their responses to this poll question. So the question is, where are young people most comfortable seeking information, advice and support in a time of crisis? Hopefully you've all had a bit of a chance to log your answers to that. And so the possible responses were telephone hotline, friends, internet, or parents. And if you voted internet, you'd be technically wrong, but not by much. In a recent survey over 15,000 young people, aged 15 to 19, the survey found that after friends, young people were most comfortable seeking information, advice, or support from the internet in a time of crisis. Furthermore, it was the primary source of information alone. And across a number of studies conducted here at the centre, we've also found that there doesn't appear to be a digital divide regarding internet or smartphone access between the general population and those with a range of mental health and substance use issues, which in the past has been a potential problem with a lot of these online treatments. So if we consider some of the barriers to traditional treatment seeking, particularly in young people, internet-based therapies have advantages regarding anonymity, reach, cost, empowerment to young people, as well as flexibility. And if we refer back to some of the major barriers faced by young people to treatment, we can see that this modality has the potential to alleviate essentially a number of these. And I won't dwell too much on some of the success of previous work regarding internet-based interventions. Suffice to say that they're essentially been shown to be equivalent to traditional face-to-face therapies, depending on how they're used, often related to input and guidance and various factors. But essentially they reveal a small to moderate effect size for depression outcomes and for alcohol outcomes. But what about comorbid treatment? Well, we know that co-occurring disorders tend to exacerbate and maintain one another, and that these conditions tend to cluster together, especially in young people. And furthermore, clients have been found to be willing to engage in willing to target multiple problems simultaneously. Additionally, this provides multiple opportunities to engage clients in strategies that generalize across conditions. So that brings me to the first major work that has been done here at the centre. And so although previously a number of different online interventions have been for individual disorders exist, the first and for a long time the only integrated computer-based treatment for substance use and depression was the self-help for alcohol and other drug use and depression, or the SHADE program, which was developed by Associate Professor Francis K. Lampkin. So originally this program was a CD-ROM package and has been found in 2 trials to be associated with equivalent outcomes relative to a therapist-delivered treatment at 3 and 12 months. The program has since been converted into an online format and is based largely on cognitive behavioral therapies and motivational interviewing. The SHADE program was originally a 10-week program, but has since been modified to include individual skill modules for those who aren't willing to complete the entire program. And the SHADE trials showed a powerful effect of assessment and brief intervention alone, and also that all the interventions used within the SHADE trial were all beneficial. However, the therapist-delivered CBT and motivational interviewing and the clinician-assisted SHADE program were equivalent, as I mentioned previously. However, this trial raised some interesting issues. Although the SHADE program was clinician-assisted, it used about 50% less clinician time. So we're essentially interested in what impact that clinician time was having. We also found there was some differences in the utility of the program for younger population, and this brought essentially to work that I completed as part of my PhD on the development and evaluation of a program called the DEAL project. Essentially, the DEAL project took the clinical components, a lot of the clinical components of the SHADE program, and as well as reviewing current literature for best practice with young people. And we created a 4-week self-help intervention for young people with co-occurring mild to moderate depression and alcohol use problems. So essentially, it's a brief skills-focused intervention focused on depression due to the difficulties in getting this population to admit alcohol problems, but then uses a non-confrontational, less direct approach to target alcohol use. We tried to increase the interactivity of the program through a range of components, including personalized feedback, user control, and a peer-led approach through case studies. And so what does it entail? So it's pretty whirlwind, but the major problem with this population was getting them to stick with the program. Thus we aim to make the program super short, so it's essentially four hourly modules completed a week apart, and the modules cover psychoeducation, assessment, goal setting, normative feedback, and mood and activity and alcohol use monitoring in week 1, followed by a lot of the heavily behavioral focused content in week 2. The third week covers mood monitoring, cognitive restructuring, and a lot of very cognitive components of CBT, while the fourth week focuses around coping skills, mindfulness and relaxation, problem solving, as well as drink refusal and reduction skills, and planning for relapse and managing relapse. And so just to give you a bit of a feel for what the program looks like, here's an example of one of the case study slides, and those are that we've tried to minimize text from the SHADE program because that was obviously a potential issue. And we trialed the program amongst 104 young people aged 18 to 25 who are moderately depressed and drinking at hazardous levels. They were largely recruited online. We ran the trial up against a attention control condition. Sorry, my computer's doing that by itself. And at post-treatment, we found that the DEAL project was associated with a 4.5 point graded reduction in depression scores compared to the control, as well as a 2-fold greater reduction in standard drinks consumed per week, and a 78% greater reduction in drinking days per week compared to the control. However, at 6-month follow-up, the improvements were maintained, however the group differences were lost. So I think interestingly the role potentially of other factors, there was no clinician contact here, which may well have been a thing, which may well have been an issue, as well as the possibility of booster sessions, and we looked into a few other concepts that might be relevant, and that's essentially where we're headed now. First up, we've used the DEAL project for a new trial that's called the iTread trial, which is currently recruiting. It's the Internet Treatment for Alcohol and Depression study. And it's the first randomized control trial of an internet-delivered treatment for comorbid depression and binge drinking in young people. This age bracket we've used is 18 to 30 years, but we've augmented it with a social networking component. So essentially, we're hoping that by the use of the social networking, we can engender a bit more use of the program and hopefully better outcomes in the long term. In this trial, we're examining the relative impact of online monthly self-assessments for 12 months alone. The monthly self-assessment combined with the DEAL program. The self-assessment the Deal Project program, and as well as the breathing space, which is the social networking component, which I'll discuss in a moment, as the third arm of this study. So it's hypothesized that participants allocated to that third arm, which also receive the social networking component, will complete more web-based sessions and hopefully report superior outcomes in the long term. And so far, we've got over 250 participants in that trial. And so this is a bit of a look at what the breathing space component looks like. So breathing space is a social network with a health promotion focus on drinking and depression. And it's essentially set up as a private group on an existing social network, health social network, and looks a lot like Facebook. So participants can create their own profile and alias, encouraged not to use their real names. And it's got quite a strict code of conduct developed for the people randomized to this breathing space. It covers general conduct, privacy, confidentiality, discussion of past experiences, trauma, and suicidal thoughts. This breathing space is moderated by staff and psychologists, and outside of core business hours, it's actually moderated by US-based coaches, which continue to monitor inappropriate posts as well as and situations in a timely fashion. The next program I'd like to sort of discuss was with both the SHADE and the DEAL project. We also noticed there was a bit of participant dropout around the point where cognitive restructuring was introduced. Following this, we made an assumption that it was one of the contributing factors was the transition from this behavioral base to more cognitive complex strategies, and the literature tends to support this as a point of as a potential issue with regards to treatment of young people. And we thought perhaps some of these cognitive components weren't translating quite as well as they could have been in our existing program. So currently we're working to develop a serious gaming component known as Shadow, which targets this area specifically. So the key features of Shadow are that a person accrues a mood score as they choose various pathways through this through this game. If they select options that are characteristic of negative mood, or those unhelpful patterns of thinking that are characteristic of depression, they lose points and are subsequently presented with a reduced range of options for the next encounter experience. At the same time, the color saturation from the game indicates that it indicates a person's mood score reduces, whereas a better mood means that the color reappears in the background of the game. At any point during this game, the person can enter a mindfulness mode and start to address the unhelpful thought patterns they've previously encountered and chosen using the key cognitive restructuring techniques, such as stopping and assessing whether a thinking error has occurred, labeling the thinking error, sort of thinking about better options and thoughts. This then resets the user's mood score and opens up subsequent options for the game player. So currently, this program is in a prototype phase. Basically, we're essentially looking at usability, engagement, and the impact on depression and binge drinking. I think we're partway through that phase. You're using a range of new techniques actually to evaluate the game, including a startle reflex modulation response, which measures emotion, which varies according to the degree of pleasantness of the experience. It's measured by the use of an eye blink response and to a loud or short noise as the user is playing the game. So we're hoping with some of these new techniques that we can get a a key component is how much we're able to engage the users, and that's been a major issue with any kind of treatment with young people. So that's what some of these new techniques are targeting, essentially. Moving on, our work has also expanded into a range of physical health comorbidities. These aren't specifically aimed at, some of these treatments aren't specifically aimed at young people, but the eHealth program, which addresses smoking, diet, exercise, as well as now there's a sleep component. This program has essentially has therapist support via email and phone-based assessment and monitoring. Although there's hundreds of wellbeing programs that are available online and in phone-based format, very few have been evaluated for efficacy, and even fewer have been evaluated with amongst people with mental illnesses. So we've come up with our own program, this eHealth program, and it's based on successful face-to-face and telephone-based lifestyle interventions in people with mental illness. The pilot study has been found to be associated with significant decreases in cigarettes per day, as well as depression scores, and that was achieved by people who are both clinically depressed as well as a non-depressed group. The pilot study also found tobacco abstinence rates at 6 months were 17% lower for the non-diagnosis group, and a 13% reduction in the depressed group. So some of the lessons we took from this trial was essentially the multi-component interventions were promising. They had similar approaches seemed to work in similar ways both for people with and without depression, and people seemed willing to engage in the online intervention which targeted healthy lifestyle factors. Obviously a lot more needs to be done, as with any of these trials. And finally I just wanted to talk about the Breaking the Ice program, which is another program that's come out of the centre here. It's essentially it's targeted at amphetamine type stimulant use. The program has been adapted from existing face-to-face psychological approaches for delivery via the internet to reduce the use of amphetamine type stimulant and associated problems, and also to improve motivation to reduce use. So the philosophy of the program is around harm minimization. So participants choose the most appropriate goals for themselves, including quitting completely, reducing their use, taking a break from use, or using it in a less hazardous way. And so the first module of the program examines key areas on which the use of amphetamine-type stimulants impacts. So a participant can select either legal issues, work and study, mental health, money, general health, relationships, just a range of issues on which to focus first. And then as we move forward, the person then selects, then is presented with 4 characters, each of whom is experiencing a problem relevant to that area of concern. Areas, for example, problems that have arisen in a work setting. Participants can then follow this character through and throughout the program. The second module asks the participants to think about the pros and cons of their use, and the pros and cons of potentially changing their current behaviour. To help with this process, for each element they identify as an issue, as a pro or con, participants can then rate the importance of particular factors in their life on a 1 to 10 scale. Finally, the third module, there's a focus on behavioural change, including techniques such as setting clearly specified goals, strategies to assist in coping with cravings, refusal skills, managing a slip or a relapse, and a plan to deal with high-risk situations. So in a sample of 160 young amphetamine-type stimulant users, while both the treatment and control groups reduced their use over a 6-month follow-up, the Breaking the Ice program was associated with reductions in days out of role at 3-month follow-up, as well as increases in health-seeking behaviour at 6 months compared to the waitlist control. So just in sort of essentially conclusion, although there's no panacea, none of these interventions are essentially aimed to completely replace any kind of skilled clinician, but the reality is that the majority of people with these co-occurring conditions, especially young people, will never receive any face-to-face intervention, and fewer still will see a skilled clinician. So I think the overall aim here is to introduce some of these therapies can be used within a clinical context by therapists as well as homework tasks. Obviously, comorbidity is an issue where a lot of clinicians are skilled in one area and not necessarily another. Again, these can provide a standardized treatment program to aid with that treatment. Furthermore, we also know that the need for treatment so greatly outweighs the resources available to the traditional service sector that even optimal treatment of mental health at optimal coverage has been hypothesized to really only alleviate about 1/3 of the burden. So these kind of programs have a range of potential advantages, especially to essentially reduce the load on clinicians, and also to help with any training and clinical system requirements. And that, I think, is essentially it for me. I want to finally just talk about some work we're doing in translating the programs into a real world setting. Currently, we've got some money to develop a New South Wales health portal for comorbidity and eHealth programs, and we're currently piloting the tool in a couple of sites. We're currently developing and piloting the tool in a couple of sites in New South Wales. And yeah, we're hoping we can get some positive results in that dissemination. So thank you, and I just want to especially thank Associate Professor Francis K. Lampkin, Dr. Louise Thornton, and Professor Mary Thiessen for their work with these programs and slides. Thanks.
Okay, thank you so much, Mark, and you've covered quite a lot of really innovative and interesting programs there. So I've certainly got lots of questions, and I've got quite a few questions that have already come through. So I hope you can clear your afternoon schedule to stay with us and answer them all. But just going back, first of all, I've had one question just come through about the prevalence stats that you presented at the start, just to check whether those are Australian statistics that you presented about.
Sure. Would you like me to flick back there?
Yeah, that might be helpful.
Essentially, the very first stats were global. They were World Health Organization stats on the overall daily. The DALY. So that was the disability adjusted life years.
Yeah.
So that one. Sorry. So that was globalized. The comorbidity prevalence stuff, that was Australian specific.
Okay. All right. And I guess you've mentioned at the end that the clinicians will tend to be trained specifically in one problem. When you've got this comorbidity, people will tend to be specialised. Do you think in the case of, say, depression and alcohol comorbidity, that maybe some of the alcohol problems are being missed, either because adolescents aren't reporting them or clinicians aren't asking the questions sometimes?
Yeah, certainly. I mean, I think that especially in young people, there's obviously a tendency to, at least we've found there's a tendency to underreport. Well, so essentially, it's they don't seek treatment for substance use. So, and again, this is largely an Australian-based. Treatment is generally set up in silos around specialisation, and they do tend to be quite specified around drug and alcohol and mental health separately. So I think that often we've found there can be a lack of confidence, a lack of training around drug and alcohol within mental health and vice versa.
Mm-hmm. Yeah. Okay. So I guess it is important for people that are working in mental health services to maybe be sort of asking some of these questions that might start those conversations.
Yeah. And like, as we also know from the literature, I think it's important to recognise that they do have an effect on. As I mentioned, they tend to exacerbate and change the presentation depending on that comorbidity.
Yeah. Okay, so you've mentioned the DEAL program. I just wanted to check. You said that was compared to an attention control. What does an attention control mean?
Oh yeah, sorry. So basically, an attention control, we developed we utilised the Australian National University program, which is called Health Watch, which is essentially a series of online questionnaires around just general health behaviours. Okay. So the idea was that it doesn't give that they get all the same assessment, as well as that the attention, they have the same time devoted to being online.
Yeah.
So we can kind of eliminate that as a potential factor and keep the groups as controlled and similar as possible.
Okay. Yeah. So you're testing whether actually giving that specialised program makes a difference above just giving them the questions. And okay. Yeah. And then it was so interesting that in the next part, what you're moving on to do is to add a social media component and look at whether that's going to, so in the iTread program, whether that's going to enhance outcomes. Can you talk a little bit about why you think the social media aspect might enhance outcomes for young people?
Essentially, I think I think there's probably a range of reasons. I think it's interesting purely from the sense that you then have what's arguably missing a lot of the time with any standalone internet intervention, especially the self-help stuff that doesn't have any clinician support or guidance, is that you essentially have no external or social kind of aspect to it. And I think what's interesting about potentially introducing social networking is that you then are introduced to a range of others, and you can with potentially similar issues. We also know that obviously that alone has potential to have benefit, just in terms of the normalization effects and those elements. But I think personally it introduces a human component, which is at times missing from internet-based programs.
Okay.
So it's I suppose the aim of it is to introduce where what currently is referred to as Web 2.0 into eHealth.
Yeah. And I've got a lot of questions coming through asking about the availability of these programs. So one person's asked whether any of them are available as an app-based, or just generally, are these programs still under evaluation, or would they be available for the general public to use?
I'll start with the app question, where I'm currently looking to source some funding to generate some app development especially for the Deal project. In terms of the availability, I wanted to mention anyone who's at the webinar, if they want to send through their, I don't know whether to you, Lexine, or myself, I don't think I've included my email, but myself or Francis K. Lampkin can be contacted at via CREMS, and we can essentially send through login details for people, but currently there are issues pertaining to essentially legal components and duty of care, which means we don't have the funding to make them freely available. We would obviously love to, and we're looking down those avenues, and hopefully this New South Wales health trial will open that up a bit more, because it is a frustrating component of doing this work and then finding the avenues to be able to release it and have it as standalone.
Okay, great. Well, so if people do want to email through, so my email address, I believe, is in your registration email. So if you email me, I'd be happy to forward those requests on to Mark to get login access. Now, we've also had some questions about the Eclipse online tool that you've spoken about in terms of, well, could you just talk a little bit more about it, and when would it be available for people to access?
Okay, sure. Well, that's currently it's actually in the very early stages of development. We're only a few months into that project, which is essentially it's a 2.5 year project. But we're hoping that'll be piloted sometime next year, and I guess it's essentially a watch this space angle. But yeah, that's the direction that's heading. Currently very early days, and it will be a portal for a range of things as well as eHealth, but that's going to be the main focus.
And so one of the questions that's come through that may relate to this asks, there's so many websites and apps becoming available for different areas of health. Do you have any advice as to how to pick reputable programs to recommend to clients? Now, I wonder, is that something that this eHealth, that the Eclipse portal is helping people to do?
It will essentially, the programs on there will be only evidence-based programs. I think I understand that frustration, because I agree there is a lot of programs out there, very few of which, I at one point I had slides for a different thing. I've got stats on the number of apps out there for mental health, and the number which are actually evaluated in any form is minuscule. In terms of advice, I would obviously look certainly at any of the developers. So anything coming via any university angle that has evaluation data is probably the best way to go. There's probably the initial, there's a lot of work currently coming out of both UNSW, ANU here in Australia. There's a lot of work coming out of the Netherlands, some work in the US around in this area. but it can be a struggle. So I would just recommend looking essentially, especially around when it comes to apps, around who the developers actually are of the apps. Are they a commercial company, and do they claim any evidence base?
Yes, certainly. And yeah, so the Eclipse portal is going to be great for that if it is a sort of a central access point for evidence-based resources where people can go.
There's also, I believe there's also a Young and Well cooperative website that they were putting together that also has their evidence-based work. So that might also be a good avenue to go down.
Okay. Now, the game Shadow is fascinating as well. So I've had one query about whether it's available for members of the public to beta test.
Not currently. I think it will be coming to that point soon. That's Professor Kay Lampkin's the head of that project, but it's essentially coming, I believe, up to that point. It's still, again, in this very early days, but I do find that quite an exciting project.
Yeah.
It does look very interesting.
Have you had any initial feedback from young people? I mean, it's such an innovative idea to be using a game like that. Have you had any feedback so far?
I think the feedback has been, really quite good. But there's the preliminary stage has just ended, and I think they're just about to start looking at the data from that preliminary testing.
Okay. All right. We'll just one last question, and then we'll let you off the hook, Mark. Thanks for that. But I do have a few queries coming through about the use of eHealth programs for older age groups. Obviously, your expertise is focusing in younger people, but do you have any idea about older age groups?
In terms of
the eHealth particularly, yeah. So I guess treating these problems in eHealth, in older people.
Specifically an elderly population?
No. I think just older than adults, rather than young people. Yeah.
Sure. I think that the majority of the SHADE program essentially was general population based. It's not specifically young people. So the DEAL program has moved, and the DEAL program and the iTread and Shadow have moved in a young person direction. Yes. In terms of comorbidity, I believe the SHADE program is still currently the only evaluated program that targets that general population.
Yeah.
Some work, I think Dr. Matt Sunderland is currently doing some work in an older population around eHealth. But I'm unsure exactly of how far along he is there.
Okay, so
his name is one to look around for, I suppose.
Yeah, for elderly people particularly. Yeah. Okay, great.
Yeah.
So the SHADE program, which you talked about earlier in the presentation. So these handouts will be available on our website as well after the session, so you'll be able to go back. But slide 23, I see here you've spoken about the SHADE program, which was developed for adults, and then the subsequent work sort of tailored the program specifically for young people. So if people are looking at programs that are effective for a more general population, then SHADE is suitable. And the other question that came through, which is related, is about alcohol-dependent populations rather than kind of less severe populations. But SHADE was actually trialled on alcohol-dependent populations, is that right?
Yes, that's correct, yeah.
Okay, so...
the aim of the DEAL project was a lot more around binge drinking, because that was clearly a major issue in that demographic. What we found was most people coming through the trial were drinking, did meet a range of abuse criteria, but their drinking behaviour was very much in a binge drinking way, whereas the SHADE program was tested in people with that were both meeting that clinical level of alcohol and cannabis use.
Dependence. Okay.
Yeah.
For cannabis as well.
Yes, that's right.
Okay, fabulous. So that ticks off another one of my questions, because someone has asked about any programs for marijuana use, but so SHADE would also be suitable.
So SHADE does target that. We didn't focus on that within the DEAL program, but that is also another avenue that we're hoping to explore down the track.
Okay, fabulous. All right, well, thank you so much, Dr. Deady, for speaking with us today and answering all the many, many questions. And as Mark's mentioned, if you do want to have access to the DEAL program or the other programs that he's mentioned, and you're having trouble finding them on our website, please don't hesitate to email me, and I will help you find those links as well. And the handouts will be available on our website, which will have all the additional links as well. So thank you very much for being part of the webinar today, and we hope to see you again at our next webinar in November, or we also have a very exciting lineup of webinars planned for 2016. Thank you and goodbye.
Thanks.